Hello, this is Anthony Effinger. I'm the host of the Think Neuro podcast at Pacific Neuroscience Institute. And today I'm sitting down with Dr. Noah Tal, who's an endocrinologist in the Pituitary Disorders Center here. And we're going to talk a lot about the endocrine system and what a day in the life of an endocrinologist looks like. Thanks for joining us.
You're welcome. Thank you for having me.
I should have said a week because I think with doctors, you have to get the week, right?
Yeah, probably.
But before we get there, tell me a little bit about your background and what attracted you to this discipline.
So I started my entire education process or journey with neuroscience. Actually, I did my undergrad in neuroscience in Israel. And when I had my first course on the neuroendocrine part of it, I just knew that that subject is like my interest. I didn't know how it would shape eventually because I was in neuroscience. I didn't plan to go to medicine, and things just shifted as they were. So I graduated from my neuroscience undergrads, and then I went to medical school and did internal medicine after that. And after that, went to internal medicine in New York. And after that, I understood that I'm going to go to endocrinology. And while I was doing my fellowship in endocrinology at Cedars-Sinai, I fell in love more and more in the pituitary disorders and pituitary gland as the mastermind or the master gland of the entire body and the hormonal balance. And I just dove right into it.
That was what, yeah. I mean, it is sort of magical and powerful.
Yeah.
It's a pea-sized gland, right?
Mm-hmm.
Like in the middle of your...
Yeah, just behind the third eye.
And how deep?
About here.
Okay, you're pointing about middle. It's middle, right?
Yeah.
I mean, it's dead center. I mean, it's hard to get to.
It's
right?
hard to get to. Yeah, I'm lucky that I'm not a surgeon.
Yeah. We've got plenty of those here. You probably work with them very closely.
Yeah.
So give us the when somebody says endocrine system,
Okay.
they mean the gland system generally?
So the endocrine system is one of the ways of our body to communicate from one place to a distant place, and from one area of the body to a different area of the body. So we have the neurons that do that, but also the hormones, which are secreted from one gland and go and affect other organs in our body. We have many kinds of hormones. You probably are familiar with insulin that is secreted by the pancreas, and also all the new medication for weight loss, GLP, GIP, those are also hormones in our gut. But we also have the pituitary gland that secretes it has two parts, and it secretes about 8 hormones. And those go and regulate the entire homeostatic systems in the body.
Homeostatic meaning
regulating metabolism, growth, energy, stress, and so on. Reproductive system.
Certainly. I never thought of the endocrine system as another communication system.
Yeah.
That's interesting way to think about it. And I guess I wonder why did the body evolve this? I mean, we don't know, right?
Yeah.
That's evolutionary biology, but it's this incredibly important, very powerful system.
Yes.
Right?
Mm-hmm.
All kind of revolving around or controlled by the pituitary gland, the master gland.
The hypothalamus and the pituitary gland. Yes.
You put those on the same.
Yeah, because the hypothalamus gets feedback, and also the pituitary, they get feedback from what we eat, from what we feel, from the body needs, and then by that regulates the downstream hormonal secretions.
Yeah. What hormones does the pituitary secrete, and where do they go, and what do they do? Just a few examples.
Yeah, we can talk mainly on the anterior pituitary. It secretes mainly 6 hormones. 2 of them is the LH and FSH, and they go to our gonads. In male, it's going to be the testicles, and in female, it's going to be the ovaries to secrete either testosterone or estrogen and progesterone. So this is the reproductive system. We have the TSH, thyroid stimulating hormone, that go to the thyroid gland to secrete a free thyroid hormone that regulates metabolism, blood pressure, heart rate, and so on. We have growth hormone that goes to the liver to produce insulin-like growth hormone that is mainly has a role in growth in children, but also in adults. And then we have ACTH. It's adrenocorticotropic hormone that goes to the adrenal to secrete cortisol and also in charge on blood pressure, immunomodulation, and stress. And we have prolactin that is mainly elevated in female who are pregnant or nursing to produce milk.
This seems like a lot to do for a very small
Yeah.
structure.
Yeah.
Right? I mean, it's incredibly important. So what brings people to you, and then and what does your week look like as a result of that?
So I would say that I would divide the patient population to two. One are patients who are already diagnosed with a pituitary lesion, and then we work up what is this pituitary lesion, and the other
Is it, when you say lesion, you mean
adenoma.
Yeah, okay.
Or
a tumor, or is that the same?
Yeah, it is the same. I just don't want to use the word tumor because usually it's benign and non-malignant. And this is why I'm saying lesion.
Okay. Yeah. I think when people think lesion, they think of, I don't know, cut or something. But yes, lesion.
Yeah.
Okay.
So like we can say nodule or adenoma,
okay.
I guess.
Yeah. Okay.
So this is one type of patient population that I get, and the other one are coming with symptoms. And symptoms can vary. It could be inability to lose weight, hot flashes, irregular cycles, cold intolerance, everything that is basically abnormal or may suggest abnormality in the hormonal system.
Oh. So you said some people come in with symptoms, and then other people, if they don't have symptoms, how do they know? Do they have a scan or something?
So either they had symptoms and their primary care physician did an MRI that showed a pituitary nodule, or sometimes just incidentally, let's say someone had, God forbid, a car accident and had a whole body imaging, and then CT was positive for adrenal nodule. For a pituitary adenoma. Or someone had a headache, and during workup, he had an MRI showing a pituitary.
Okay. So when somebody comes in with a pituitary lesion, I guess it depends on their case, but what are the courses that they might take through PNI?
So in PNI, we have a multidisciplinary team. We have me and endocrinology working on the endocrine part of it. We have the neurosurgeon that would intervene if needed surgically. We have the ophthalmologist to see if there's any, because the pituitary gland, it sits right below the optic chiasm, it can sometimes compress and you have a vision abnormality, so they'll assess that. And we have, of course, the ENT who works together with the neurosurgeon and surgery. When I have a patient that's coming with pituitary tumor, I think about either this tumor secretes a hormone.
The tumor does?
Yes.
Okay.
And if it does, what hormone? Or if the tumor or the tumor leads to hormonal deficiencies. So sometimes it's the tumor itself is a specific growth of a specific cell of the pituitary that can be over-secreting a specific hormone. Let's say it's ACTH, growth hormone, prolactin, TSH, it's quite rare, and LH and FSH is even rarer. But so the main hormones that are more common are the prolactin, ACTH, and growth hormone.
Okay.
That I would first think of. However, sometimes when the tumor is big, it can compress normal cells and cause hormonal deficiencies. Not just that, the entire feedback of the hormonal balance, either from feedback from our body, but also from other hormones, can cause deficiencies. For instance, elevated prolactin will cause low LH and FSH, will actually shut down the reproductive axis. Elevated cortisol will also lead to a low LH and FSH and shutdown of the productive axis. Because if you think about it from evolution standpoint, when you're in stress, when you're nursing and you have a little baby, you don't want to have more kids.
Okay, right.
Yeah.
So it makes sense. It's saying shut this off for a time.
Exactly.
Yeah.
So those are the main two patient populations. Yeah.
Is the pituitary any more prone to lesions / tumors, adenomas than any other place in the body?
Not necessarily. I think that all of us probably grow a lot of tumors and nodules. If we're going to do MRI or screening MRI for everyone, we'll find something.
Really? Yeah.
Yeah. For instance, about 40% of people just in the street will have thyroid nodules.
Really?
And 10% will have pituitary lesions.
Really?
Yes.
1 in 10?
Yeah.
But okay, what percentage of those would be sort of harmless? You'd never know about them.
Yeah, exactly. Most of them.
Most of them.
Yeah.
Okay, well, that's good news.
But with time, when we have more and more screening and more and more imaging, we find more, and then we do more workup. But most of them are clinically insignificant.
Okay, that's good news.
Yeah.
So you've got a gland that's the size of a pea. Is that correct? I think that's from my high school biology. But how big are the tumors or lesions that you're talking about on there?
Yeah.
I mean, it's got to be tiny, right?
So it can actually vary. It can be very small, like a few millimeter, like 4 millimeter, 5 millimeter. If it's up to 1 centimeter, it's called microadenoma, like small adenoma. And if it's more than 1 centimeter, it's called macroadenoma.
Centimeter.
Yes.
Like, is that the diameter or the radius or what?
It's it can be up. It can be not like diameter. Yeah.
Okay.
Yeah.
Ballpark. Okay.
Yes.
So that's
Even
bigger than the pituitary. Isn't
yes,
it?
and it can even grow up to 5 centimeter.
Really?
Yes, and in very, very, very rare cases, when you have more aggressive lesion, it can really occupy a big.
But there's not a lot. I mean, isn't that sort of a crowded area there?
Yeah.
It must begin to. Is that when it starts to affect the?
It can affect the vision when it's at large. It can affect other structures in the brain. Yeah.
Yeah.
Because there's
it's
no
all there, right?
Yeah.
Okay.
But this is very rare.
That's those large.
The extensively large.
Extensive.
But you can see definitely 2, 3, 4 centimeter. Yeah.
That's incredible. I didn't know they could get that big. We should probably talk about Cushing's disease. Tell us what it is, and what do you do in those cases?
So, what is Cushing's disease?
Yeah,
Cushing's disease is a condition where your body has elevated levels of cortisol. Cortisol is our stress hormone, and it's secreted by the adrenal glands sitting here just above our kidneys. But it's regulated by the pituitary and the hypothalamus, right? There are many, before we go there, so the symptoms for Cushing disease, and then it's also, I'll tell you the symptoms and you can understand why I get patients that not necessarily have Cushing, but have similar symptoms, are weight gain, inability to lose weight, diabetes, hypertension, insomnia, depression, anxiety. So those are all symptoms that we can see in population who don't have
right.
Cushing. Yeah. However, when you have Cushing and when you have elevated cortisol and you have the symptoms, and you can also see physical signs that are more specific, like abdominal stretch mark, which are slightly purple, or you have fat accumulation here above your clavicle or behind your back, or blood clots.
Wait, is all that caused by more cortisol? Well, that's why? I mean, maybe we're asking impossible questions, but
so cortisol breaks down the protein in the skin.
Okay.
And it's not just stretch mark because you're getting fat, but it's also stretch mark that associated with the breakdown of proteins in the skin. This is why the purplish look of it.
Interesting.
Yes. So then you suspect Cushing, you suspect elevated cortisol, and you know it comes from the adrenal.
Sure.
But the question, why? Yeah. Is it the adrenal itself that secretes a lot of cortisol because there is another adenoma in the adrenal, which is also quite prevalent? Or is it coming from the brain, from the pituitary that secretes elevated ACTH? There are other reasons for elevated ACTH. For instance, if you have a neuroendocrine lung tumor that can secrete ACTH, or you have elevated CRH from the hypothalamus, but those are very rare cases. So the most prevalent cases are either independent cortisol secretion from the adrenal or from the pituitary. And in order to separate between those two etiologies, we're going to check the ACTH. Because the beauty in the endocrine system is the feedback.
Yeah.
So if you have elevated cortisol because of the adrenal, the ACTH in the pituitary will be very low
Okay.
because it's a relationship.
Yep. Yep.
But if the cortisol level is elevated because of the pituitary, the ACTH will be high. So this is how you can differentiate.
That's great. Yeah. Right.
And then if the ACTH is elevated, we're going to do a pituitary MRI. We may or may not see a lesion or a pituitary adenoma because sometimes they're small and it's hard to see them. But if we see, the next step would be to refer to neurosurgery, and then they will take it out.
Yeah. And that's where PNI really excels, right? I mean,
Yeah.
some of their founding procedures were transnasal, going through your nose to get to the pituitary
Yeah.
and remove lesions, correct?
Yes.
And that was groundbreaking. That's Dr. Kelly and company
Yeah.
doing that. I mean, obviating the need for massive surgeries.
Yes.
I don't know what did you do? What did they do before that?
The craniotomy.
Meaning,
They open, the skull.
okay, all right. So it's great to have that tool in your toolbox, right? I
Yeah.
mean, so you'll see these patients. Are you sort of the first line in the endocrine disorder? You know, I mean, obviously somebody's
Yeah.
PCP,
Yeah,
primary care
exactly.
doctor,
Yeah.
physician is going to be. But are you at PNI? Where do you kind of fall in the?
So again, it's parallel.
Okay,
Because
okay.
sometimes you will have patients that are coming with pituitary adenoma due to just imaging, and then we'll find out on the way that they have Cushing, and sometimes they'll come with symptoms of Cushing, and then I'll evaluate and find that they have elevated cortisol and a pituitary adenoma, and then we'll refer. It's really hard to say. There is not like a straight linear line, because that's the beauty, actually. It all happens in parallel. It's like one-stop shop that a patient come, and whoever they need to see, they see that day.
Because there are alternative treatments.
Exactly.
You're not necessarily surgical.
Yeah, no, so specifically for Cushing, the first line treatment would be surgical.
It would be because that's a
Yes, that would be.
yeah. Okay.
But then there are other aspects to think of. First, the normal ACTH secreting cells in the pituitary are suppressed, meaning that the patient would be adrenal insufficient right after the surgery. If indeed the surgery took everything out and the patient does not have this pituitary adenoma.
Okay.
Okay, so after surgery and the patient is presumably adrenal insufficient, I follow them closely to make sure that they get hydrocortisone or cortisol replacement therapy to make sure that they're not adrenal insufficient, because this is a life-threatening status.
Being adrenal insufficient. It's because
Because
what's
we
the
need-
life-threatening part? What is it?
Yeah, it can cause initially the symptoms of adrenal insufficiency would be nausea, vomiting, abdominal pain, dizziness when you stand up, but it can also cause hypotension, inability to fight infections, and death.
My gosh. Okay. And that's when you don't have enough adrenaline.
Yeah, cortisol.
Cortisol from the adrenal gland.
Yes,
right.
exactly.
So cortisol gets a bad name a lot of times, right? We hear about it being a stress hormone
Yeah.
and, lower your, watch out. But it has a very,
Important role in our life. Yeah,
Yeah.
but like everything needs to be in moderation.
Exactly,
Right? Not
yeah.
too much, not too little.
right. Some of these
Yes.
things I think get tarred with,
Yeah.
the stress hormone.
Exactly.
But we learned recently there's eustress and distress.
Oh, and
Yeah, right. I mean, there's good stress,
yeah.
right? That keeps you,
Yeah.
alive and functioning. And
Yes, exactly.
Yeah.
So I will see those patients and make sure that they're not adrenal insufficient, that they're getting the cortisol replacement therapy they need after the surgery. And many times it may take a few months, but it can also take up to a year. Their normal ACTH cells recover.
Okay, that was my next question.
Yes.
This therapy is temporary
Yes.
while the gland is recovering.
Exactly. And then most of the time we can taper them off of it. And then we need to think about recurrence, because it can recur. The tumor can grow again. And then the question is, what are we doing? Are we going again to surgery, which is definitely an option? Are we going to do radiation therapy, which is also an option depending on the location of it? And we also have medical therapy that we can use for Cushing disease.
Medical meaning
medication.
medications.
Yeah, to
Okay.
block the production of cortisol from the adrenals.
Okay, right. When you say radiation, is that gamma knife?
Yeah. Yes.
That's when you
Yeah.
get the beams that meet,
Specifically to one
Yeah.
area where
because you got to get right in there. And, I mean, that's a miracle in itself.
yes, definitely.
Right. I mean,
Yeah.
yeah, that's another wonderful thing to have around. Okay, so that's Cushing's disease. What else? What are some of the more unusual cases that you see? I mean, there must be just innumerable puzzles
Yeah.
in this system, right?
Yeah.
That you can.
So I had a patient that was like it took us a little time to understand what she had. She had nipple discharge. She came for nipple discharge, meaning she had, or in the professional language, galactorrhea, milk discharge from her nipples.
Not when she's
Not pregnant.
nothing.
No.
Okay.
She had a brain MRI because of that, and they show like a 3 millimeter lesion, like very, very small. That may be a different lesion, not specific to pituitary adenoma, but something that is called Redke cleft cyst that usually does not secrete anything. So, and we checked her prolactin level, obviously, because this is, the number one reason for why a patient who is not pregnant will have galactorrhea would be elevated prolactin level.
Which is the hormone that causes lactation.
Exactly.
Okay.
And it was normal. And we did it again.
Prolactin was normal.
Yeah, and it was normal again. And we did other studies like dilution prolactin study to make sure that we don't have an issue with the assay. And it was again normal. And then after reviewing her medication list, which is the number one thing that any doctor should do when they see a patient, I saw that she has a medication that is used for ADHD that actually leads to excess of dopamine. And dopamine suppresses prolactin.
Okay, so excess dopamine from the medication, the dopamine suppresses
the prolactin.
Okay, keep going. This is
so
you're on the trail now.
Yeah. So I told her, listen, you have to stop the medication so we can have a diagnosis. Like, we have to see what's going on.
Yeah.
Just on, like, off note, she had irregular cycles and she was trying to get pregnant but could not. So we stopped the medication and she repeated the labs and the prolactin was elevated. We started her on treatment, which is a dopamine agonist, because I told you that dopamine suppresses prolactin.
Yeah.
She stopped having
So wait, you gave her a medication that did what? An agonist is
agonist increases dopamine.
Okay, you want to increase the dopamine.
Yes. In order to decrease the prolactin. Yeah, this is
all right. No, it's good. I'm picturing the levels going up and down.
Yeah.
Okay, go on.
Yes, exactly. Because this is the beauty and the endocrine system. So we gave her cabergoline, which is the medication for prolactinoma, a tumor secreting prolactin. Her prolactin went down. She started to get irregular cycles. She stopped having galactorrhea, and she got pregnant.
Wow.
And that was very
Wow.
rewarding and satisfying.
I'm sure. So, okay, so the key there was getting her off of the ADHD medication.
Yes, in order to have a diagnosis that we can treat.
Because that was throwing
everyone
a variable that, yeah. Wow, that must have been gratifying.
It was.
Yeah. So how long was that arc?
I think it took a month.
That's not bad.
No, it was fine.
How long had she been dealing with these other symptoms?
I think it was for a couple of years.
A couple of years. And had she been to like other doctors and specialists? How did she come here?
Yeah, she was referred by a neurosurgeon because she had a pituitary lesion.
Okay.
But not because of the galactorrhea. But it is interesting because I have to tell you that I had a few women that came with galactorrhea, with lactation, for years and didn't think it was odd.
Well, I mean, okay,
Yes.
people put up with a lot of
Exactly.
And so when they got here, they were like, hey.
Yeah.
They finally was like.
Exactly. Okay. So we worked that up
and
felt.
And what was it? Was it the sort of same process with them?
Yeah. So when prolactin, if you have galactorrhea, or lactation, you have to make sure that it's not the elevated prolactin. Sometimes there's something that is called a hook effect, when the prolactin level is too high and the lab cannot measure it. So you have to do dilution study in order to have the real value of it.
It's so high that you can't measure
Yes.
it? You mean it's like
It's
off the chart?
saturating. It's saturating the assay, and it cannot be measured.
Whoa.
So we do a specific study for that, and then we can see. Other just different and similar topics. Sometimes I have patients coming with elevated prolactin, but no symptoms. And this is also something that we see a lot, and also family practitioners see that a lot. And the reason for that are a few. Main ones would be medication. So many psychiatric medication lead to elevated prolactin, and not necessarily need to be stopped because of that, and not necessarily need to do anything about that, but just to rule out a tumor.
Yeah.
And there's another reason that is called macroprolactin. Now, macroprolactin is actually aggregates of prolactin coming together. And it's not clinically significant, but the lab reads it as elevated prolactin. So some people just like to clamp their prolactin together.
And that's asymptomatic?
Yeah, exactly. So we check for macroprolactin. We see if this is the reason why the prolactin is elevated. And if it is, that's it.
That's it.
Unless you have a pituitary adenoma and also you have symptoms, and then that's a different story.
Yeah.
But if you don't have an adenoma and you don't have any symptoms, and it's only just the microprolactin that is elevated, then definitely that is the end of the
Yeah. There's a kind of a wonderful internal logic and function. I mean, the whole body is that way, but this seems, quite sort of stark in the sense that, this goes this way, this goes this way. I mean, it's kind of,
You have to think.
You really do. It's a causal cause and effect.
Exactly. And you have to look at the whole body and the whole person, because this goes up, this goes down, this makes this, and like, a negative feedback and positive feedback and everything. Like even not just medication and macroprolactin lead to elevated prolactin, but also stress, any nipple like if you have any itchiness or rash in your nipple area, so many things can cause that.
Signals.
Yeah, that signals too.
Yeah, that's interesting. I think when many people in America hear the word endocrine, they think of endocrine disruptors.
Yes.
I mean, is that just too big of a topic to get into, or are those a thing?
I don't know much of that, although I should. It is a thing.
It's a thing.
It's a thing.
Okay.
And I think that we don't know too much, and it's very complicated. As just the baseline endocrine system is very complicated, and just add all of those endocrine disruptive hormones that can disrupt your reproductive axis, that can disrupt your satiety and hunger and your emotional stability. So all of these they do have a role in our hormonal balance.
Okay, but that's sort of the new frontier.
Exactly.
Because all these things are all super new.
Super new.
As we've developed the ability to create these crazy molecules.
Exactly.
Yeah. Okay, so any other interesting cases or cases that I guess we've talked about the most common things that bring
that
people
I see.
in. Yeah. So how do you work with the other doctors at PNI? Do you meet every week? Do you talk about cases, or how does the communication work?
Yes. So we're basically sitting, door to door from each other. And if I have a patient that I would like to be seen by the neurosurgeon, that I'm gonna ask them to see, or I have an imaging that I want to review with them, so I just go to them and I said, listen, I have this patient, can you walk over with me on the imaging to see if there's a pituitary involvement there? So it's really on a daily basis. It's like, this is, as I said, the nice thing in PNI. And it's not just in the pituitary. For instance, I also see patients with thyroid issues, and one of them would be Graves' disease. And Graves' disease has a component of thyroid eye disease. So if I do suspect someone who has thyroid eye disease, I can just refer them to our neuro-ophthalmologist.
What does that look like?
Thyroid eye disease.
Yeah.
And thyroid eye disease can have multiple presentation. It can be only itchy eyes, dry eyes, some redness. When we think about thyroid eye disease, we have the bulging,
right?
But it can be much more subtle than that. So it's very important for patients with Graves' disease to be evaluated by a neuro-ophthalmologist to make sure that there is nothing there. Because sometimes it's not that of a clear cut when you look at the patient and say, it has.
What is the mechanism? Why does the thyroid affect the eyes?
So it's not the
thyroid. Or do we even know? Or go on.
Yeah, so it's not the thyroid that affect necessarily the eye, but the antibodies, the thyroid stimulating immunoglobulin that attack the thyroid also has effect on the protein behind the eye.
Okay.
And those protein behind the eye causes inflammation and irritation and actually pushing the eye outside.
Okay, so that's a concurrent issue, but one's a clue to the other.
Yes, exactly.
Okay. So how much of your time you spend on treating thyroid issues? Are those fairly common?
It is very common. Hypothyroidism, hyperthyroidism. Yes, those are common. I see. How much of my time?
What causes that? Do we know?
So it's autoimmune. Sometimes there are tendency to autoimmune disease. Sometimes it can be sporadic, meaning you're the first in your family. But many times I see patients that have multiple family members with either thyroid autoimmune disease or other autoimmune disease. So it's mainly a tendency.
Right. Okay. So it could be genetic, could maybe not be.
Yes.
Okay. So how long have you been at PNI?
6 months.
Yeah? How's it going so far?
I love it.
You happy?
Yeah, very much. Yeah.
Well, you have a great bunch of colleagues, and
yes, the colleagues are wonderful. The patients are wonderful. The hospital that we work in is also fun. St. John.
Yeah, right across the street here. Mm-hmm. Yeah, so you've got it all in one place.
Yes.
And it happens to be in Santa Monica, which is nice.
Yeah, you can always see the sunset.
All right, Dr. Tal, thanks for joining us. This is really interesting. We'll do this again as you're here longer.
Thank you.
Thank you.